Hi, it's Dr. Swarbrick. How's everybody doing? This is the voiceover PowerPoint for digestion and inflammation. So it's going to cover Module 2 and 3. Module 2 and 3. So it's going to be a combination of concepts of digestion and the concept of inflammation. So to clarify, inflammation is a concept that's covered in 114. Digestion, however, is not a concept, nor is it a concept that I can locate in your Gideon's textbook. So for the first half of this PowerPoint, you're going to need to follow along, take notes, etc. And then the inflammation concept for Gideon is chapter 22. So when I get there, just if you have Gideon's available, that's great. If not, that's totally up to you how you want to use it. So the rationale behind the concept of digestion is because our exemplars for Module 2 are upper GI. So upper gastrointestinal, which is peptic ulcer disease, pancreatitis, cholecystitis, or inflammation of the gallbladder. But everything we put in our mouth from a digestive standpoint can aggravate the inflammatory process if, in fact, we have an issue with peptic ulcer disease, cholecystitis, and or pancreatitis. So it's important that we talk about the concept of digestion because it is truly interrelated. So basically, the moment I put food in my mouth, we are releasing enzymes. And so when you hear the word enzymes, go back to your chemistry days, and enzymes are usually a chemical reaction that begins the breakdown of fats, starches, proteins, vitamins, and minerals. And that's why it is so important that we understand the concept of digestion, because so much of what the upper GI and the lower GI from an inflammatory standpoint is a direct result of some form of digestive malformation or the kind of diet our patients have that is precipitating gallbladder attacks, for example, which is usually high fatty foods. So with that being said, we're focusing more on the chemical breakdown of the concept of digestion versus the mechanical, okay? So that's kind of what I got. So normal digestion is, let me just scoot through here. That's our goal. That's that goal. So digestive system, put something in our mouth, pharynx. The pharynx is the tube trachea that goes to your lungs. Your esophagus is what carries your food to your stomach. And then you have three parts of your small intestine. So off the stomach is the duodenum. Then the next part of your small intestine is the jejunum. And then last but not least is the ileum, which attaches to the right lower quadrant that begins the large colon, which is primarily responsible for reabsorption of water, reabsorption of nutrients in making stool. Okay, so for Module 2, we're dealing with the upper GI. So we're dealing with the stomach, the gallbladder, the pancreas, and part of the small intestine. All right, so that's what your enzymes do. They assist in this nutritional component of making vitamins and minerals so that we have sources of energy to function. So I'm not going to talk about the motility so much, but that is part of the peristalsis. That is part of those sphincters that are part of the muscular contraction or process that's moving food product from the mouth to the swallow to the stomach. And then the process of digestive enzymes in the stomach that breaks it all down into chyme, which is CHY, M as in Michael, E. So chyme is the, pardon the expression, the mush of the solid foods has now been broken down by chemical enzymes such as hydrochloric acid, pepsin. So these are very acidic type of enzymes that, due to other sources, can cause someone to have peptic ulcer disease, which is part of our exemplars in Module 2. So it's really important that we understand, again, the activities regarding the process of chemical digestion. You'll hear me sound like a broken record throughout the semester. The more immobile somebody is, the slower and sluggish the digestive system will become. the amount of stress we all have as nursing students and nursing instructors and just stress of life. We talked about with elimination, the concept of elimination voiceover, focusing on urinary versus stool or defecation. We do talk about GERD, which is gastroesophageal reflux disorder, as it relates to peptic ulcer disease. Pyloric stenosis relates to pediatric gastroenteritis. Then, of course, we have IBS, which can either be inflammatory or irritable bowel, but we do inflammatory. And enteropresis, and now that I'm just going to butcher that, just be mindful that I mispronunciation school, probably K through 12. So I'm always a Google girl, and so I will not be offended if you correct me. But this particular term, if my memory serves me right, refers to pediatric bowel problems, etc. All right, so we're going to move on. So when we have an alteration to the digestive process, what ends up happening is that your body is missing nutrients. We need fat to keep us warm. We need sugar to keep us energized. We need proteins to heal. We need lipids. We have good lipids and we have bad lipids. But the good lipids help coat our arteries to improve motility and perfusion so we don't have clots, heart disease, set us up for strokes, etc. So when you have disease processes that affect the digestive system, upper and lower, and by lower I mean just the large colon and the small intestine, such as Crohn's or ulcerative colitis. So be mindful that patients with colostomies and ileostomies, and remember I mentioned with the suffixes of ileostomies and colectomies, this is where you start seeing medical or surgical conditions that will hinder absorption of these nutrients that help maintain body mass index or BMI. Other components when we look at mental health and anorexia, when we look at bulimia, when we look at other things that's all encompassing around the digestive system. And I mean, not that you're standing in front of me, but eating is a social entity. Eating with others is culturally makes people happy. Socializing, and not being funny, digesting the day, talking at the dinner table with our kids and our families. Eating alone is a solitary function that can cause psychosocial concerns and can preemptively increase depression and or anxiety in our patients. So it's important that we look at this particular concept in a much more holistic fashion, if you will. All right, so alterations and manifestations. So nausea, vomiting, anorexia, and when this has got in parentheses loss of appetite. So you can be anorexic without having anorexia bulimia. Anorexia nervosa or bulimia are mental health diagnoses. Okay, anorexia here in this PowerPoint for loss of appetite is specifically related to some type of disease process that's causing someone to not be hungry. Folks with cancer receiving chemotherapy or radiation can lose appetite. That's just an example I have. GERD, we're going to talk about. Hepatitis, you get in 211. And hepatitis, the hepatic is Greek or Latin for your liver. And as you know from your 117 days, your liver is the only organ pretty much in the body that manages all of your metabolism. So everything we put in our body by mouth, by IV, any orifice is absorbed and metabolized through the liver. Malabsorption, maldigestion, we talk about those in a couple of weeks, as well as pancreatitis, cholecystitis, and as I mentioned, pyloric stenosis. So I'm going to move along fairly quickly because what you're looking at is mostly 211 content, but I like to think when I teach holistic health concepts, I'm teaching the prevention of having somebody become having a chronic disease. So when we teach preventive medicine with peptic ulcer disease, which is a chronic disease preference, we can improve our overall population to reduce acute exacerbations. Your Nursing 211 class is about chronic disease management. And so I take it to teach preventive management of care to reduce the incidence or frequency of folks with chronic diseases. All right. Genetic factors. Well, we can't fix the genes. We can't fix the family history, which is also known as your non-modifiable. And I talk a lot about that. What can't I change? I can't change my race, my color, my age, my gender. I can't change the family history, and I can't change the genes. So that's what I'm stuck with, right? But I can change modifiable lifestyle. I can change diet. I can change how much I smoke or don't smoke, how much I drink or I don't drink, excuse me, how much mobility I want to have in my life, how much sedentary lifestyle I want to have in my life, the use or non-use of street drugs versus pharmaceutical drugs. I can make choices that can adjust those modifiable, changeable processes that can improve my non-modifiable. What can I do to potentially reduce my risks because I have non-modifiables that I can't change? All right. So, for example, Crohn's and ulcerative colitis typically are a direct result of gender, race, and family history. But by diet and management of medications to reduce the inflammatory process, I can modify and reduce the risk factors of frequency or increased exacerbations, which means hospitalizations of these disease processes. So that's what we basically focus on. The concepts, fluid electrolytes, I'll be gentle, I'll try. You get a lot of your fluid electrolytes and acid base when you're in 112. And I know you're going to be looking at me with deer in headlights. And I promise to come back and review as we get toward the end of the semester, because at that point you would have had this content for 112. So metabolism, liver, nutrition, I've already spoken to. Development over the lifespan. Pediatrics, we'll talk about the gastroenteritis, and then the self-management is definitely the concept of self falls into mental health, especially with disorders such as eating and personality. So obviously with health promotion, I talked already about the fact that we can change those modifiable factors and we can make choices on how we manage our lifestyle. Okay. And as I said in the elimination for the urinary system for module 1, the basic presumption is to ensure that we are getting adequate water consumption, we are exercising, we are using diets such as the DASH diet and diabetic diet that covers the colorful table of food, or a plate of table that is color coordinated and not just gray, such as fried foods, French fries, white bread, things of that nature, so that we can be more healthy. And we're living longer because the advances in medicine and pharmacological agents are promoting longer life. But remember, the longer life is coming when we're older. So even though we're older and our natural body is beginning to decline, naturally, we may end up living longer with that because of the advances in medicine and drugs. But that doesn't mean the quality of our life is better as we get older. Talked about those. We'll talk about especially early diagnostic testing. I mentioned the elimination with the PSA markers for prostate CA. Breast cancer I just briefly touch on because of mammograms. Colonoscopy is huge. So we do talk about that, and your hepatitis screening is done in 211. Well, care in the community teaching. So for your nausea vomiting patients, usually they're NPO. We drop an NG tube to low wall suction. We'll talk about that. The BRAT diet is capitalized. So anything you see capitalized is an acronym. So bananas, rice, applesauce, toast, really big in our pediatric patients. We do a lot of post-op teaching in our class because of the GI issues that we discuss. So folks obviously are NPO until we have peristalsis and bowel sounds. And then we start advancing clear liquids as tolerated. Over-the-counter medications, there's a lot of meds in this class, and we really talk about medications because that is part of management of care. If you don't know, you do now, that there are a lot of complementary or herbal medications that the CDC or the FDA, Federal Drug Administration, does not research or do testing on. So we really don't know how a lot of these medications affect cardiac meds, digestion meds, inflammatory meds, and mental health meds. So some of your biggies are St. John's wort, saw palmetto, ginger, garlic, and then glucosamine, which is used for over-the-counter for arthritis. We'll get into those much more as we dive into our, as I said, in elimination module week 1, we get into the medication classification, and I give you a prototype. Because once you know the prototype for the medication, then you can pretty much sing away the rest of the meds in that classification. Don't eat before going to bed. Don't smoke. Avoiding spicy or acid foods. And so if you listen to this before I talk about it in class, there really is not a lot of research that supports avoiding spicy foods with peptic ulcer disease. And I'll speak more to that in class. I mentioned lifestyle. Sorry, it's kind of PowerPoint's a little jacked. Digestion in older adults, everything slows down. Older adults with cancer, anorexia comes up, malabsorption comes up. So malabsorption means that even though I'm eating well, and by well I'm getting adequate, moderate amounts of all the appropriate food categories I'm supposed to have, but I'm not absorbing said nutrients. So therefore, my body's not getting what it needs to function. Okay. Did you know that you need fat for cognitive function? Not only to stay warm, because that's why you have hair on your skin, your head, and your legs, is to keep your skin warm, to keep that internal metabolic temperature. But we need fat not only as an insulator, but fat also promotes cognitive thought. Protein is for healing, so etc. So this makes sense, I think, for all of you. All right, so that's your digestive system. So have at it. And we'll speak, I apologize for turning my head away. We will speak to like the role of the pancreas, the role of the liver, the role of the stomach in much more detail when we get into discussing the digestive process and how it gets screwed up when we talk about those inflammatory disease processes happening to those organs. So with that being said, with Gideon's chapter, what did I say, 33? Nope. Chapter 22 is your inflammation. Now, I know in 111 you had inflammation other than, 31 other concepts, no pun intended. But with inflammation, you have your 5 cardinal signs. And so think about those ahead of time because I'm going to ask you what they are. But I do know that when you have an inflammatory process that's happening inside the body, we can't see it, quote unquote, right? So we're going to talk about blood work that can help us with markers of an inflammation. We're going to talk about how your patient's going to present, what kind of assessment you're going to do to confirm your hypothesis that there's an inflammatory process going on. And so those are some of the things that we're going to discuss both in Module 2 and 3. So obviously inflammation is a process where I call it the army, which is where your white blood cell army, let me back up my bus. So when you're looking at labs on a patient, so the providers can do 2 things. They can order what's called a complete metabolic panel, which is going to be your electrolytes, your BUN, your creatinine, your LFTs, which is your liver function tests, ALT, AST, and there's a couple others. But when the CBC, the complete blood count, we'll give you your H&H, and then it's going to give you some other values with the hemoglobin, which is basically the size and shapes of some of your red blood cells. But my point being is that you have what's called the white blood cell family. All right, so you might just see the words WBC, but the physician can order a white blood cell panel. That's going to include all the family members of the white blood cell kingdom. So you have neutrophils. So when you think neutrophils, you're thinking new white blood cells. That means there's a new infection. So you would have an elevated neutrophil, okay? Leukocytes are old warriors. So they're hanging out in the body. They're waiting for a chronic disease to become exacerbated, and then they rise in the proliferation, making more of them to go and try to help with reducing the acute exacerbation for the chronic. There's other things, there's other components that will, as a result of the damage to tissues or to muscles, will be activated. All right. And so there's basophils, there's eosinophils, and all of that has to do a lot with allergic reactions and antihistamines. So when you see white blood cells by itself, you don't have the laundry list of the white blood cell family. So unless the provider orders that in addition to, you just have an elevated white blood cell. You don't know if it's a new infection, and you don't know if it's an old infection. Those are things we're going to talk about. My bad. Well, then you don't have to tell me in class, because there's your 5 manifestations. Erythema, what is that? That's a medical term for redness, right? Heat, which means I usually think of a wound or something we all can see. So you put your hand over it and it's given off heat, swelling to the site, pain because of the swelling, and impaired function, depending upon where the injury is. So you can have physical, chemical, and when you see the itis, pancreatitis, cholecystitis, endocarditis, appendicitis, that's an inflammatory process. So again, when you get to your canvas in a couple of days, you're going to be able to, it would probably help if I did that, sorry. You're going to, there's 2 places in course resources and clinical where I provided a suffix manual or resource. I'm a paper girl because I'm old, but download it so that you have the suffixes that you can use both in class and clinical. I'm telling you, if you haven't taken the medical terminology courses here on campus, suffixes will be your best friend. And that has a lot to do as well with suffixes for medications. Like you guys did a med template on lisinopril or captopril. Well, the suffix is pril, P-R-I-L. That means it's an ACE inhibitor, manages blood pressure in the kidneys, and I call them the pril sisters. So when you have suffixes like that, you're not beating your head against the wall, because you understand the classifications of pril sister. So therefore, it's an ACE inhibitor, manages blood pressure using the kidneys. Therefore, I must have good kidney function to use said medication. Moving on. So I'm not going to get into the complexity. The point is understanding the inflammatory management of care, because it's multifaceted. All right, so I'm going to go back one and tell you why it's multifaceted. So pain. All right, got to manage pain. It's your 5th vital sign, right? Impaired function. I have to improve patient's function. So that's problem number 2. I have to reduce the swelling. So how am I going to do that? Do I have an infection? What does my white blood cell count look like? Where is my swelling? What is that swelling doing, and how is it impairing the function of that organ, that tissue, that muscle, etc.? Erythema and heat are all representative of an infection. So when we get to the nitty-gritty of managing the inflammatory process, you're going to see your nursing care plan, aka also known as your concept map or your outlines, are going to paint the patient puzzle and put together how we're going to manage the care for this patient. And you're going to learn to prioritize which you're going to take first, what you're going to do first as an intervention, then number 2, number 3. Then you have to evaluate, did it work, did it not work? If it didn't work, what am I going to do to fix it? All right. So I'm not going to get into, we talked about acute and chronic, that I think acute is an exacerbation, typically resolves in less than 3 months or sooner. Chronic is long lasting, typically greater than 6 months. I'm not getting into stages of inflammation. I'm not testing you on it. But I do want you to see here where you see leukocytes and leukocytosis. So again, the suffix here is of OSIS, means that the inflammatory process is beginning, but has yet to become an itis. So leukocytes is those old warriors I just mentioned, the white blood cell family. Leukocytosis is the proliferation, the start of reproducing multiple leukocytes to ward off an acute exacerbation of a chronic problem that's going to occur. Okay. So as we know with wounds, for example, what we can see, you have the erythema, you have the heat, but what else can we have with wounds? With the UTIs, we can give off an odor. We can have drainage that is non-healing, non-healthy looking. So pus, greenish drainage. Anybody see a wound with MRSA in it or gangrene? So those are parts of inflammatory process. And then we repair the process. I'm not going to necessarily get into that. I will talk about heparin when we get to cardiac for blood clotting. Not going to talk about some of those other white blood cells that will eat away of the debris, and that's your macrophages. This is more of your biology component of your inflammatory process. And when you open your textbook in Gideon's, it talks about acute versus chronic, and then it gives you pictures about the actual process of what your white blood cell family and its distant relatives are doing to reduce the inflammatory process. But let's talk about medications. So an inflammatory process is not the same thing as an allergy. An allergy can cause an inflammatory reaction, okay? But it doesn't mean that every time someone's exposed to an allergy, they're going to have an inflammatory reaction. And that's when I mentioned that histamine, such as your basophils and your eosinophils. But we have Benadryl. It's an antihistamine. We have nonsteroidal anti-inflammatory drugs such as Aleve, Motrin, Advil, etc. Folks can have allergies to latex. Peanuts are huge in kids. Shellfish is huge when we think about IV contrast dye. So we're going to talk about those things. Milk and eggs as it relates to flu vaccines, etc., etc. Bee stings, so people should be carrying epinephrine pens around with them, etc. So inflammatory process or inflammatory pieces have a much larger holistic approach than just your 5 cardinal signs, and that's what I'm selling. So with this particular slide, rheumatoid arthritis and lupus are chronic inflammatory disease processes of the body fighting against itself. I don't talk about RA or rheumatoid, but I do talk about it, how it affects the increased risk for peptic ulcer disease based on medications. Lupus, we talk about that when it comes to chronic glomerular nephritis. So when the body has the inability to recognize something as part of itself, that it's a natural component, it will be in a permanent state. Permanent's not fair. It'll be in a state where the body is chronically fighting itself. So that's what rheumatoid arthritis is. It's a joint deformity, specifically in the hands. So there's just that piece of it as well. And then lupus I'll talk about. But the whole point is that you can have an inflammatory reaction pretty much anywhere. So common disorders, you can see I'm going to talk about pancreatitis, gallbladder disease, inflammatory bowel. GERD, we cover appendicitis, believe it or not, you get that in 112. Asthma, COPD, you get that in 112. Cellulitis, you probably covered that a bit with 111 with wound care, part of your skill sets. So you can see a lot of this is going to come in 112, stuff you've already had, and then stuff you're going to get in 114. And thyroid disease, you do in 112. So we talked about the classic signs of inflammation, the healthy inflammatory reaction, and it is healthy. It is healthy for the body to produce neutrophils. For a new infection, it's the body's way of protecting itself, okay? So it's really important that you recognize that it is normal. But the biggest problem with this is stress-induced chronic inflammation, such as rheumatoid arthritis, systemic lupus, Raynaud's disease is another one. Multiple sclerosis is another one. And so eventually the body gets tired. And as we get older, I've already said, stuff starts to go downhill anyway. And then if you're fighting a chronic illness, your body's just tired. And so, again, quality of life can be diminished, even though we may live longer because of medical advances. Yeah, again, inflammatory diseases are significant causes of death. The chronicity in this country, for me, the fundamental layer that starts the whole downward cycle is type 2 diabetes, and you learn that in 112. So someone with type 2 diabetes will eventually can have a whole body decline of cardiac instability, vision instability, sensory instability, and kidney failure, just to name some. So the number of chronic diseases a person can have is in effect what is causing the increased death rate in this country. And so diabetes is one particular platform that lays the premise for other disease processes to become a part of that person's medical record, if you will. And then impaired mobility or lifestyle modifiers that aren't done. Mobility, obesity put together in addition to diabetes and other health conditions increases the chronic disease management decline that we're struggling with in this country. And whether you work in healthcare or not, in whatever role you work in, or your family members, whatever your exposure is to healthcare, nobody gets admitted to the hospital with just an exacerbation of one disease, because we're managing everything else in that medical record, because what's in that medical record is pretty much the direct result of why that disease has exacerbated in the first place. So, it's a problem. I talked about non-modifiable risk factors, and we'll talk about that as it relates to individual exemplars in class. These are the concepts that some of them are related to inflammation. So immunity, diabetes will destroy the body's ability to ward off infections over time. Mood and affect, when someone has chronic illnesses, increases depression and anxiety risk factors. Oxygenation with COPD, again, part of Maslow's airway, breathing, circulation. And safety, increased falls, increased breaking of hips, increases morbidity and death rates in women and men before the age of 60. So basically, we do a lot of teaching in NUR 114, because what can we do is to find out from our patients, A, what is their learning level, what is their learning style. I'm teaching you, right? So I want you to turn around and teach your patients. But how do you learn? Are you a visual learner? Are you an auditory learner? Are you a hands-on person? Are you all three? Are you 1 out of 3, 2 out of 3, etc.? So if I can't effectively teach you because I don't know your learning style, then you're fiddling your thumbs for the next 16 weeks. No offense. But you have to go into your patient's room and say, hey, tell me how you learn. Are you an auditory person? Do you need videos? Because I can pull up YouTube videos all day, or I go to the CDC, or I can do this, this, and this, and I can teach you how to test I can teach you how to use a glucometer. I can teach you about how to test your blood sugar. I can teach you how to give yourself insulin. But you have to understand how they learn, because you're just spinning your wheels, right? So we have to know how they learn so we can best teach them, because I don't particularly want them frequent flying into the ED and back on the unit, 2 weeks after they went home. That's no quality. So we're going to talk about health promotion for Crohn's and ulcerative colitis and peptic ulcer disease. We're going to talk about pediatric gastroenteritis, because the primary thing with that is hand washing. This is bacterial transmission from hand to mouth. And so these kids are in the hospital dehydrated because they're vomiting and having diarrhea, and these kids are little. Their body surface is tiny, so they can't be dehydrated without their kidneys shutting down. Okay, I talked about that. Exercise, high fiber, low fat diet, but in moderations, ideal weight. Modifiable, yeah, I can fix diabetes. I can fix hypertension. Let me just answer. No, I won't answer it. And I'm not going to get on a soap wagon. I may get on my soapbox, but I won't get on my soap wagon. People make choices. Okay, I already talked about that. So we can do all the teaching until the sun comes home, or whatever your phrase you want to use. Chronicity of disease processes, exhausting, absolutely exhausting. So I hate the word non-compliance, because when you walk into a patient's room and you're there on the unit for 12 hours, and you have, in a best case scenario, 2 patients, say, in the ICU, or 4 patients on a unit, which you're probably going to end up with 6 at some point in life. How much time are you really spending in that patient's room? Think about it, especially when you're just starting out. So let's talk 5 years down the road when you think you're seasoned. How much time are you spending in that patient's room? Who's doing the teaching? Who's not doing the teaching? How many times has this patient been in the hospital? How tired are you of seeing them? Well, maybe you should flip the dialogue and say, I can't imagine how tired they are of seeing me. So I hate the word non-compliance. So we have to learn, and I'm not saying you don't, and I'm not saying you don't have this intrinsic factor about you, but we have to flip the dialogue and try to be empathetic. I don't need you to be sympathetic, because when you become sympathetic, you lose your objectivity. I need you to be empathetic. I need you to make change. Why I still teach is to teach my students to make change. Teach your patients how to take care of themselves. If they don't want to anymore, there ain't nothing you're going to do about it, but be empathetic to where they are in the road of their life, not yours. They are not a pain in your butt. They don't want to be there. And maybe they do, and that's a separate conversation. Anyway, I got on my soapbox. Hypertension, we can treat that. We can treat it with medications, but they're not going to go on meds initially. It's going to be lifestyle, diet management, low salt diet, exercise. Your heart's a muscle. Muscle's time. Dietary factors, we talk diet all semester long. So I'm going to sound like a broken record. Fast food drives gallbladder issues. Low fiber foods causes constipation. Foods high in sugar causes yo-yo of blood sugars and a glycemic index, and it promotes inflammatory reactions on our body. So let's eat vegetables and fruits and fish and whole grains and a lot of olive oil. Well, do your patients have access to this? Do they have the money for this? You know, most of the United States of America is rural. So access to health care and poverty, socioeconomic status, education level, family traditions, family cultures, family dynamics, cultural congruency. Those are tough battles to fight. So we do the best we can. All right. But diet is a huge factor in pretty much everything we're going to talk about this semester. Yep. Fish oil. Great thing. Omega-3s, omega-6, they're great. This just it helps with digestion of vitamins and minerals. So we talk about screening. You'll do your thyroid stuff in 112. Skin testing, that's a tough field for providers to be in. But sometimes when we have trigger factors such as bee stings, peanut butter allergies, other food allergies, folks have, histamine reactions and inflammatory issues. So the screening piece of it comes into that. As I said, inflammation affects any part of the body. We do our assessment guided by our patient's presentation. That's your clinical assessment. That is your manifestations. And then we begin the fishing expedition between our assessments and what the doctor or provider is going to order that drills down to what's going on, so we can get a plan in place with orders to intervene accordingly. So basically you can read this. I think it's sort of self-explanatory. I've talked about it throughout this nursing concept voiceover for you. We are going to talk about how vital signs are impacted by inflammatory reaction. Obviously, temperature can go up. Respiratory rate could go up from pain. Apical rate or radial pulse will go up due to pain. So we are going to talk about some of the educated guesses you're going to have about how your patient's going to present. So diagnostically, I want to talk about two inflammatory markers. One is your ESR. I'm not going to test your own values. And then C-reactive protein. Doctors typically will draw one or the other. It's sort of ridiculous to draw both, but they're generic markers. So what I mean by that is it tells the provider that there is an inflammatory process going on. It just doesn't tell you where. But it can help confirm, for example, that there is inflammatory going on because of how the patient presents. So it's part of the fishing expedition, but it's an appropriate test to drive. And then the white blood cell, and this is what I was looking for, the word differential is going to give you that white blood cell family, the leukocytes, the neutrophils, the eosinophils, basophils, etc. Those kind of things. All right. So those are diagnostics we're going to talk about. Interventions. these are based on what's wrong with your patient and what the provider is going to have us do to manage the inflammatory process. Teaching, I'm a big teacher. That's why I do what I do. So we're going to talk about those teaching components as it specifically relates to our exemplars. Everybody, don't work at the bedside alone. Collaborative teaching is huge. Dietitian, big, huge, awesome. Impaired mobility, physical therapy, occupational therapy. Those of you that did rehab for 111, you know, sometimes they'll say PT works on the lower half and OT works on the upper half. Either way, you know, maybe we need an OT or PT referral. Maybe someone had a car accident and they have a shoulder dislocation. That's a upper body mobility issue, inflammatory process. Maybe they need OT. So you can see where those kind of therapies can be interactive in that particular stance. Dietitians, well, you help me. Stroke patients, quadriplegics, amputees, things of that nature that are going to impair mobility. Complementary health approaches. So probiotics, I will touch on. I will touch on probiotics because when folks are on, especially your elderly folks that are on generic or broad spectrum antibiotics, it kills all the good bacteria in your gut. And your gut, to me, is your colon where you make stool. And so probiotics can sort of regulate the good flora and the negative flora. So the good flora is what we want in our body because it wards off what's called opportunistic infections, such as C. diff. All right. So it's mindful that probiotics, and if you've seen, I know you didn't pass meds in 111, but once you finish your MAC exam for 112, pass your MAC exam, you are free to fly and pass meds. But I will talk about that in clinical orientation. Acupuncture, cognitive behavioral therapies, we talk a lot of CBTs in mental health. Exercise is sort of self-explanatory. We'll talk about pharmacology as it specifically relates to medication, so don't lose your mind too much with this slide. Surgeries, we talk about surgeries as it specifically relates to our disease processes. We do talk a lot about post-op care and pre-op care. You get your pre and post-op also in 112, and I'm a firm believer that redundancy and repetitive discussion on topics helps students retain and can apply information better both for patient care and academic success in both classes. As we get older, things kind of get a little wacky. So we have to take into consideration the patient's age, the gender, and the race, because that all plays a role in the patient's presentation. And that, my friends, hopefully less than, I think I might have done it in less than 45 minutes or so. Anyway, cool beans. This is awesome stuff, and we are moving on. Guys are great. See you.